Hi and welcome. Thanks for joining us as we talk about insulating your practice from potential cold fronts. This is a big topic as things have been going on in the last few months, and we just wanted to bring you some updated information and updated thoughts as we go through the middle of this year and plan for the end of the year. My name is Greg Auerbach. I'm a senior director here with Schein Dental Practice Transitions. A couple of quick reminders: this course is not eligible for CE credits. And if you have any questions throughout the presentation, please feel free to drop those into the chat, and I'll be happy to get back to you or connect you with one of our local transitions consultants to get that question answered. But we love questions, so please send them over. To talk about what we're going to talk about today, I'm going to give you just kind of a brief update as to where we are with valuations and sales as far as the market review goes with Schein DPT. We'll talk about some current trends in dentistry in the United States, as well as the economy itself, because that's really the core of the presentation is, what are we going to do, or what can you do to insulate yourself in the case that maybe the economy goes in a different direction, or things are not as good as they have been for the last few years. So in that, we'll talk about teaming up for security. We'll talk about how you could identify decline in the practice itself, and with that, mistakes you may need to avoid or may want to look out for to avoid as you go forward as well. And then we'll wrap up pretty much as we always do if you've joined us before, with what we think is super vital for you and something that is very core to me and my time in practice transitions and valuations and the partners that I've had in business for emergency exit strategy planning. Just a little background about me. Again, my name is Greg Auerbach. I'm currently a senior director here with Schein Dental Practice Transitions. I take care of our valuations and our operations teams. So everything mechanically to keep things moving for your transition, that is part of my responsibility. I have an MBA from Wake Forest, as well as an engineering degree from the University of Central Florida. So I have a core baseline in numbers and logic and methodology, which has lended well to practice transitions and valuations over the years. I've been doing this for over 20 years now. I've probably personally evaluated well over 1,000 practices, mostly here where I live in Florida, but I've also worked nationwide. I've actually evaluated and consulted with a couple of practitioners internationally as well. I have been an associate. I bought into my business. I was an owner for my business, and I sold my business. So many of those things that we talk about for you in transition, I have been through myself in some way, shape, or form. And up until I took this job as a senior director, I was a salesperson and working with you on a day-to-day basis in your practices. And for the last 5 years, and basically almost the entirety of the time that we have been with Schein Dental Practice Transitions since my company was acquired, I was a top producer. So I was very busy in what I was doing, very active in our markets. And again, just by attesting to the 1,000 plus practices that I think that I've evaluated, have been seen a lot, and which is what we tried to bring to you and what I tried to bring to you in these conversations. Personally, I live in Orlando. I am married. My wife, Veronica, and we have 3 girls, Scarlett, who's 7, Alice, who's 6, and Colette, who's 4. So my personal time is spent with dance. Now it's gymnastics as well, piano. And they're big Disney fans. So we live not far from Walt Disney World and spend a lot of time on Disney cruises, as well as you could imagine with 3 girls, if you could guess, who love both Bluey and princesses. So Disney's great for them. I do have a team though. We have a team nationwide. We have the largest single company nationwide for practice transitions and valuations. As you can see on the map, this is our coverage for our transition sales consultants, as well as our support team, our valuations team, and our operations team, as well as management throughout the country. So we really, truly do cover the entirety of the country, including Alaska and Hawaii. So wherever you are located, wherever you're listening to us, we are here for you. We also have a team in Canada. We have a sister team in the UK. So again, we are not just the United States, although I'm talking to you on behalf of our US team, but we are an international operation as well, with a family of companies doing practice transitions and valuations and sharing information really, which is something that is unique for our Schein DPT team and Schein overall. Just to give you some perspective of where we've been as far as valuations and sales goes, Our company alone since 2021 have done almost 2,000 practice valuations, and that is attesting to almost 2 million of practice value. So we've been very busy just over the last 2 years. Since 2023, in 2023, we did 424 practice valuations at almost 400 million in practice value. Last year we did 423, so almost the same exact amount at $430 million in value. But what we were bringing to you and what the important piece is that practices over that time, because again, we did almost exactly the same number of practice valuations, went up over 8% in value year over year. So practices on the whole are appreciating and getting more valuable over time. There is still some strains in the market that we'll talk about that are benefiting value and benefiting sales, but we're certainly seeing it in our evaluations themselves. Last year for practice sales, we did 234 practice closings, and those would just be straight those doctor to doctor or doctor to DSO transactions, and that's representing over $190 million in practice sales price. So there's a lot of value being transferred back to you as owners, and those of you who were retiring and walking away. Again, it was a very busy year for practice transitions. So far this year, we've completed 152 valuations, coming in at just over $151 million worth of practice value. So you can see values are staying relatively steady, and we're staying still very busy. This is just through May. This month we've been quite busy too, but since we still haven't concluded the month, I didn't want to get you those numbers all the way, but we'll certainly update them throughout the year. But again, as you can see, we are very active. This breeds a very large database of data to be able to reference from. Again, probably the largest database in the country to be able to not only work on for valuations, but as we have these conversations about where practices are, where your practice stands, what you can do to improve your practice, we have the core data to be able to look at and generate that advice, an expert on the ground guidance for you, as well as through other resources to make you and your practice better over time. A little perspective on the landscape of dentistry overall in the United States. It still is a seller's market in most of the country. It has been for quite a while. Certainly there are parts of the country that end up being more of a purchaser market if you might be in an area that may be more sparsely populated or may not be as attractive to purchasers overall, and you typically kind of know what that is. We find those practices are actually really strong in most cases, and in a lot of cases, they are significantly more profitable and often a better deal because there's a lower market for them, but they typically don't have as many purchasers. But again, in most of the country, if you own your practice, you are in at least tilted to your favor to be a seller's market. Practice values, as I spoke about just a minute ago, are continuing to rise, and they're continuing at peak levels. They're amongst the highest that we've ever seen overall for practice values. And again, as I was talking about the market, there are more purchasers than sellers out here. The average retirement age is just under 69, which has been pretty steady over the last few years. But what has been changing in the last 5 to 10 years is that while in the early 80s and late 70s, we had a very large number of dental schools that closed down as we went into the late 80s and early 90s, therefore depressing the number of purchasers coming out of dental school. Over the last 10 to 15 years, and especially in the last 5 to 10 years, a number of dental schools have opened or reopened in some cases. Therefore, we've now added more purchasers and more graduates coming out of school. Therefore, they're more able to purchase practices, again, tilting the practice marketplace back to sellers' favors. So essentially, just like any other product that's out there, when there's more demand, value goes up. And as we have not reached a place, even though the ADA has expected the surge of baby boomers, and to be honest, I've written about the possibility of a surge of baby boomers and why it's that much more important to keep your practice in tip-top shape, both operationally and aesthetically. We still haven't seen this surge come about, And in that case, like I said, with the growth of dental schools opening and additional graduates coming out of school, the market has continued to be in seller's favor. You can see on the bottom left, kind of a comparison between 2010 and 2020 of where the population base is by age. So you can see that in 2010, it skews a little bit younger than where it is in 2020. As we are awaiting updated data from the ADHVI as well as the Bureau of Labor Statistics, we are seeing a spike in younger population, which again is leading to this idea where the marketplace is still balanced, if not to your favor as an owner, because there's more purchasers, more younger practitioners out here than there were in the past. There are other challenges out here, and this is something that I wanted to bring up in the scope of conversation later, especially as we start talking about how to talk to patients overall. This is a Time article that has just come out this month. It's entitled "America's Dental Health is in Trouble." And in the case that you didn't read it, the headers of the article talk about why dental care is an afterthought, about fluoride bans and just out of reach solutions. All of these things swirling around dentistry right now, amongst every other topic that has broadly been out there. There are a couple of notable quotes that I saw in here, and they're both from practitioners that Time spoke with. The first talked about worrying about someone dying because of an abscess cavity that develops into infection, and then they won't be able to access care. And this is a primary topic that has come up year over year over year, especially as we look at rural dentistry, and some states have looked to target how can they have practitioners come and fill those rural dentistry holes. But this is a big, major, significant topic overall, and it's really pretty much in every part of the country. With Dr. Forney's endpoint being that she's gone to Haiti 9 times and have never seen the level of decay that she saw when she worked in Florida, which is not something that I really want to take ownership of, being a resident here in Florida. But it's a reality that's out here, and it's an opportunity that's out here. The second piece comes from Dr. Simon, talking about the Association of Poor Dental Care and how those relate to other medical care and medical issues, including pneumonia, diabetes, heart disease. But her last point being, it's obviously there's a cosmetic piece to what is done in your practices overall. But in reality, it's cosmetic. There's the medical complications, but then her last point, well, what if you can't even be taking in the nutrition that you need to fulfill your body? So I bring these points up because they're salient. They're obviously out there in the market. But when you're talking to patients and the importance of care, especially if we go into a more constrained or challenging time as far as the economy goes, and patients looking at how they're taking care of themselves and how they're interacting with you as a practitioner, the more conversations that you're able to have and relate what you do and the services that you provide on a whole body health and overall health basis, as opposed to just a cosmetic type level choice or just getting out of pain, is something that can really make a huge difference in case acceptance and moving forward with different treatments, especially when cash becomes tight. Which again, this is something we'll talk about a little bit more, but I found this article somewhat enlightening. Again, a lot of it had to do with changes as far as the federal government goes in Medicaid and potential Medicaid funding, but the points that came out of this really are beyond Medicaid funding alone. It's really about, again, to me, how you're approaching your patients, how you're communicating with your patients, how you are communicating treatment plans and the need to execute them and follow them all the way through, as opposed to just, again, a cosmetic upfit. Speaking of the economy, as we will do later, as related to your practice, uncertainty continues to reign. Every day there's positive and negative stories either way on the economy, and it's a little bit hard to parse through. As you can see, I just gathered some of the top headlines that were out here if you were just doing a quick search on the US economy itself. Yahoo Finance talking about paralysis as well as a hiring slowdown. The street.com talking about corporate bankruptcies being high. Wall Street Journal talking about the uncomfortable summer of the economy being ahead, again, citing uncertainty and not knowing exactly where things are going or what is going on. Market Watch talking about the economy being stalled in May, and that's coming from the Fed. It's not coming from Market Watch. Morningstar.com alone, though, has conflicting and contrasting comments. GDP contracted, but not yet alarming. Consumer spending is at odds with sentiment, which we'll talk about in a second. The labor market, though, is holding steady, but all of these articles that talk about that are talking about also that the changes in the federal government have not necessarily hit the labor market yet because of severance packages and such that are still out there. So there's still uncertainty that's there. The inverted yield curve, if you're really into the finance component, where short-term yields are yielding higher than long-term, meaning people are expecting to get or wanting a higher yield in that short-term money over long-term, and long-term is fairly low. And this is one of those indicators, although not alone, of a potential recession, but it's one of those things that gets watched. And again, the stock market volatility that's out there, but again, analysts expect more. Speaking though about the Fed, you can see the graph on the right, or I'm sorry, the map on the right, with a lot of our country in contraction, especially west of the Mississippi. You can also see in the tan area of no growth and the green where there's slow growth. There's nowhere that the Fed, through its different offices throughout the country, is indicating that there's significant growth overall. And I think that there's, in reading through what is there, concern even about the slow growth states that you can see in green, potentially turning over to becoming no growth and potentially more of contraction overall. So again, not one of these is a specific indicator, but it's one of those reasons that we wanted to come to you today to say, well, just in case, this is the time to start planning. Now is the time to start putting things into place to figure out what you can do in the case that something actually does happen. Because when something does happen by way of a recession, we don't know it until we're actually in it. It's not actually going to be reported on that way. So again, the more that you can do to plan ahead, the better position that you'll be. I talked about sentiment a minute ago. This is a graph showing hard data and soft data as far as the economy goes. So the dark blue line is hard data. So that would be data out of the government, like the Bureau of Labor Statistics, unemployment rate, interest rates, the hiring rates, and the number of jobs available. Those are all the hard data. So that's in dark blue. In light blue is that soft data. Those are the feelings. Those are the ones that you see most colleges or other institutions that are out there doing different surveys to ask what consumer sentiment is. And there's a significant gap between what the feeling is and what the reality is. And that's pervasive throughout the country. And obviously we've had an uptick early in the year or late last year, but that's declined again as we look currently with some reporting right now that gap is even wider. So again, we're not looking and saying that anything at this point is in some alarming position, but we want to position you to have the right information to make the right decisions to go forward and make your practice even better to hopefully withstand if something does come. So the core of what we're talking about though, and obviously the core of your profitability ends up being two things. One is the amount that you're able to produce and therefore collect, and hopefully your collections is very close to what you're producing. But then also controlling overhead in your practice overall. And in some cases you can control this, and in some cases you cannot. In most cases, most of your overhead is a fixed expense. It's something that's not really recognized by a lot of practitioners, but we sit down and really talk it through. You only have two variable expenses, and I know that's an MBA term, but there's only two real variable expenses in your office, which are laboratory and dental supplies. And obviously, if you are a surgical practitioner or an endodontist, you might not have a lab expense, or those may vary. But again, those are the only two options really for variable expenses. Oftentimes, a practitioner will say, well, my staff is also potentially variable. And I'll say that it actually isn't, because You don't hire more staff when a new patient walks in the door. You might need more staff as many more patients walk in the door, which actually relates wages more to a step function as opposed to a variable function. Things like rent, insurance, in most cases, advertising, your telephone and utility costs, repairs and maintenance, all of these stay relatively stable throughout your time, especially if you're in a single location and you're utilizing that full location. Therefore, those are all fixed expenses. And again, that ends up being most of your expenses once you've included wages and contract labor. So if you see here, you can see general practitioners here on the first column, and then you can see if you're a specialist, would it be endo, surgical, orthodontics, pediatric, perio, or prosthodontist, where your overhead typically would expect to lay out. This is for $1 million office. Now, mind you, this is not just our data. One of the national lenders actually uses basically these guidelines on underwriting. So it's something that is really pervasive throughout the country and something that we end up when we're doing valuations also work to match up against your practice to figure out, where can you perform better? But when you're looking at your financial statements, or if you're working with us or working with your accountant, this would be one of those tables overall that would be very important to kind of target. Again, not every practice has every expense like this. Some places, especially more rural or suburban areas, may have a rent that is significantly lower than 4.2%. That said, if you're in Manhattan or downtown Chicago, or Marco Island in Florida, or maybe somewhere in the middle of Dallas or another major large city in the country, your rent could be significantly higher. It could be 10 or 15% of your overall overhead. That's a cost of doing business, and we can't do anything about that expense overall. But it's something to keep in mind when you're, one, establishing a practice and growing your practice, because again, it will be a fixed expense for your practice, and there's only so much that you can do about it. For profit margins overall, again, this is all owner operated. We expect GPs to be around 39%. That would be your take home without debt service or anything else. If you're endo or surgical, you get to take home a lot more, mostly because your staffing is significantly less. There are cases that you can have a smaller facility as well, where you don't need as many chairs available to do the same amount of work. And obviously, you don't necessarily have a lab expense associated with your work. So a lot of those pieces that end up contributing to you being able to take home significantly more, and also have significantly higher buffer in the event that something does happen. You can see ortho, pediatric, and perio all generally run in the same profit margins, all still higher than a general practitioner. And prosthodontists, who function very similar to a lot of general practitioners, typically have a profit margin right in line, especially because their lab and their supply expenses typically end up being a little bit higher than most practitioners would be, due to the level of care that they're providing and the level of service they're providing. So if we talk about overhead and we talk about maximizing and really generating the most you can from your overhead, one of the requests that we get a lot is, well, how do I then team up? How do I bring more practitioners into my space to make my space more efficient? And there are really three ways to do that. And the big pieces of those, one is an associate. The other is to have a partnership with another practitioner. And the third is a solo group or a group solo. And we're going to talk about each one of these and kind of the mechanics of how they work. So an associate, just by baseline, before we get into the details, we really need your practice to be very well established. Ideally, we're going to have optimized staffing, systems, processes. Essentially, you are running as efficiently as you possibly can, and then you have a phantom practice out there that we can bring an associate into. Ideally, we're going to have collections over $1.2 million per year, and this is really for a general practitioner. So for specialists, it may be a little bit different. It could be higher, it could be lower, and that's the same for the area. But broadly speaking, roughly 1.2 million plus a year. And then new patient flow, we want to see at least 2, but ideally over 4 new patients per day on average. And the reason that is because we need to fill your schedule and we need to fill an associate schedule at the same time. So 2 would really give 1 and 1 to each of you. 4 would really give either 1 to you and 3 to an associate, or 2 and 2, depending on how you go. But really, we need to look to build that associate schedule. So we need new patient flow to be able to support that. So essentially what we're talking about is if you're open 4 days a week on most months, that would be 16 new patients per day, which would be maintaining your current practice. 32 would be the 2 average per day, and obviously 64 would be 4. So if you are seeing 64 new patients per day and you're optimized otherwise, then it may be time to talk about an associate. That said, we do need to have somewhere for that practitioner to operate. While I have seen less, my ideal is that you have a minimum of 5 to 6 operatories, because that gives 1 to 2 operatories for each of you, plus at least 2 for hygiene. But then really, I'd like to see you at 7 to 8 operatories, because that would give you 2 operatories apiece, plus 3 to 4 hygienists. Depending on how many hygienists then you have, you also have an overflow room. So we have seen cases where there's an associate in a 4 or 3 operatory practice, but it gets very, very difficult. There's nowhere for that practitioner to work. And I will tell you that most younger practitioners are not interested in late hours or weekend hours to try to extend the hours of your practice. So we really want to find space for them and patience for them to continue to operate alongside you, which means, again, we have to have a facility size and a new patient flow to be able to support that. So another choice beyond an associate is a partnership. Similarly, we need a practice that is well established. And in reality, we'd like both of your practices well established. Because if I take 2 practices that are not, then we've just created a third that is even more chaotic than either the 2 were separately, because we have 2 practitioners now trying to run them. So similarly, optimize staffing, systems, and processes. This is a matter of everybody understanding what it is that you have as far as practice goes, how you want to practice, what you need in practice, and where you want to go, and be able to put those together to then be able to minimize your overhead overall. One positive and one chaotic doesn't really work, because the chaos ends up taking over the positive and the really strong practice. You have to have everybody truly like-minded and in a direction of where you want to go to be able to be truly successful as far as a partnership goes. Another model, if you haven't heard about it, is a solo group, or again, this group solo. This is really boiled down to multi-practice space sharing. So you practitioners would each own your own practice. You'd be operating over the space, out of the same space. I'm going to detail this a little bit more and show you a little image about how this kind of works. But in reality, this solo group model is the most profitable out of practice modalities. And it's really the most flexible as well, which is if I have a choice and you're talking to me about multi-doctor type practices, the solo group model is where I would prefer you to be for a whole host of reasons. But let's dive into all this a little bit more. Let's talk about associates first. This is typically the most requested and the most simplistic way, and we do have a team that can help you find associates at Direct Dental Services. You can reach out, just put a note in the chat over there. We can get you connected if you think that you need an associate. But we have a team that this is all they do nationwide. But the associate structure is that you as a owner, you own the practice, you continue to operate the practice, you call the shots. The practitioner that you bring in is hired as an employee or a contractor. Now, there are a lot of considerations to bringing someone in as a contractor, so it's something to think about and talk about with local legal counsel, and review that also with your accountant as to whether they should be a contractor or they should be an employee in your practice. But those both carry different considerations on how the agreements are affected and how the relationship is maintained. In any case, the associate is paid on production or collections. Ideally, again, your collections are very close to production, and so it doesn't matter. There's something else called net collections that's out here. It's basically production minus refunds or minus the insurance non-payment amount. The big thing here about production versus collections is that in most cases, in most practices, the associate has zero control over the ability to actually collect money in the practice. Therefore, having them paid on collections themselves is not something that they have their hands on. They don't direct the way that the front desk operates. They are not necessarily interacting with insurance, which is why we think it's probably fairer to work on some sort of payment based on production. But again, you can use that and adjust for the fact that obviously, if you have a UCR of $1,500 for a crown, but you know that that PPO will only pay $1,000, that perhaps you're paying on the 1,000 and not the 1,500 because that's essentially adjusted or net production. In any case, there needs to be a legal agreement to establish a relationship. It may be a very short agreement for the first couple of months just to make sure that everybody is working together well and everything is going smoothly, but there should be a full detailed agreement later on. Benefits of this is that you're able to retain ownership control of your practice overall, and then you can probably or potentially provide additional availability of practitioner hours. That could be at extending hours. But even so, again, if you have a practice out there where you're not able to fully service all of the goodwill and the demand for your services, having a second practitioner in means that you can see more patients. So there's essentially a doubling or an addition of practice hours, depending on how many hours that associate is working. There are, of course, complications in any one of these. And in this case, you do need to support the associate, and that's both in staff, so there's additional costs involved, and patients, as we talked about before, making sure you have solid patient flow, and you solidified that so that they can continue to operate and grow a practice. There's potential chaos in the practice because it's not just one practitioner, it's two, and you don't necessarily operate the same way. They may not have the same expertise. They likely won't as you. And so, again, with additional staff and additional operations, there's just additional chaos, which you will need to manage. This is one of those reasons that we like to have your practice as fine-tuned and as strong as possible before going down this route. For an associate, there's a lack of ownership interest, so it's very easy for them to leave. There's nothing really tying them to the practice. With that also, and in most of the countries, these are still enforceable non-competition and non-solicitation agreements, which I'll talk about in a moment. But these are all considerations and potential complications to bringing in an associate. So speaking about non-competition and non-solicitation, these are different agreements, although they're typically tied together. So a non-competition agreement says that the person who is signing and agreeing to that, the subject of that agreement, cannot operate or own, typically in any way, shape, or form, so even passively, any other competing practice or business within a certain radius. This would include association or working somewhere else, or even, again, a partial or some sort of passive ownership. They're typically all-encompassing. Something else called a non-solicitation agreement. So this is where you say that the subject of the agreement cannot market to the patients of your practice. And again, this is typically, though, addressing like active marketing, therefore like calling the patients, sending direct mail to the patients. That would not typically include something like a big billboard that the patient may see, but it's about directly soliciting and contacting that patient base to get them to go somewhere else. So a lot of times a non-competition and a non-solicitation agreement will go together and be hand in hand, but they are separate components of agreement as well. So something to certainly look out for. There are restrictions on non-compete and non-solicitation agreements, and there's a lot of conversation that's been out there. So I strongly urge you both to check agreements that you may have, but talk to legal counsel. They all need to be where they're enforceable, reasonable in distance and duration. So how far they approach and how long. And that's not one answer for the entirety of the country or even a state. Even the type of practice or where you're located within a state could have a different distance and or duration. Something that would happen in Manhattan is likely very different than something that would happen in more of a rural area of, say, the Midwest. The number of patients that are accessible and how they access practices are very different, obviously, in the different areas. And therefore, when a non-competition and or a non-solicitation agreement is crafted, those local jurisdictions and those details matter. Even having an ocean, a bay, a lake, or a river could matter. Distance is usually based on the practice drawing area. and can be limited. Duration is typically 1 to 2 years after an associate leaves the practice. But again, all of this is governed by local, state, and potentially federal jurisdictions. So please check your statutes and talk to legal counsel about these. As we look, though, I present this graph, and this is really a startup to maturity graph. And I answered it here because, again, we're talking about practice growth. And this is we're going to talk about as we get into multi-doctor modalities, moving through this graph. So if we talked about this practice growth model, if we look on the far left, this is starting at 0 and 0. This is somewhat atypical for an actual practice startup, but we use it for the model. If you look at the two lines, the collections are in red, expenses are in blue, and you can see that expenses over time rise and then they level off, because as I talked to you before, expenses in a lot of cases are fairly flat and fixed in your practice, while collections will grow. The area on the first part of the left is where you're actually losing money to operate the practice. You don't have collections to cover your expenses. You reach this crossing point where you actually make $1 and you have profitability in your practice, and then you continue to grow going forward. And this is where we like you to get to, is this area of optimum benefit. This is my term. This is not some sort of term that's actually out there. But this is when we actually see you making money in a practice. And depending, again, where you're located and what type of practice you have, this could be anywhere between $500,000 and $800,000 worth of collections. This is, again, where you start really making money and seeing cash flow. Where we like to get you is this area of optimum practice. And this is where you're really making a lot of money. You've covered your fixed expenses, your practice collections are really grown a lot, and you're seeing like 80 to 90% of what you're producing as additional dollars coming to the bottom line. This is where we want to get to you. This is that area, if you're in optimum practice and you're continuing to grow, where we would see an associate come on, although it would somewhat reset you back a little bit. But also where bringing two practices together could jettison you into this area of significant profitability. But ideally, this is where we would get all of your practices and let you live and enjoy yourself. So as we talk about multiple practice or practitioners, let's talk about a partnership. So these are considerations, and you can see on the right, there's kind of structure that we're talking about. We have 2 doctors owning a single entity, which everything is owned by that partnership. Everything is commingled. You have one set of financials, and all income and expenses are in the partnership itself. So your benefits overall are coverage. You get to cross coverage. You get to, be friends and colleagues and talk to each other about different cases. And in some cases, you have cost savings because, again, you're sharing space and you're potentially sharing other expenses in the office. There are complications that go along with this, the clarity of the structure itself. Partnerships can be very convoluted overall. My old partner, who I bought out of the business originally, when presenting, would hold up a cup of cranberry juice and a cup of water and mixing them together. And what do you have? You have one color. You don't have two. So everything is getting commingled and working together. So having proper counsel to address how this partnership is put together is very important. You do need cross agreements for death and disability, and a huge complication in what we see a lot of are poorly developed agreements on both ownership and operational. So what we talk about as far as must go, you do need to have a formal legal relationship. Again, there's IRS factors for this, as well as including what tax returns you file. You should have a compensation agreement which specifies all issues related to compensation. Everything should be outlined. It should be something that's talked about up front. It may be modified over time, but it really should be addressed early on and upfront to go forward. The operating agreement is specific guidelines for practice and business operations, as well as control, management, and decision-making. A non-competition and non-solicitation agreement is important here in the case that you guys break up. And there's cross-insurance or buyout provisions as well about how, if something happens to either one of you. We say this 3 times because it's that important. I say it a lot in presentations. I'll say it now. I can put you into a partnership on a cocktail napkin, but how I get you out or how a legal mind gets you out is very difficult. So ultimately, the biggest important piece of this is your dissolution agreement. And these should be as detailed as possible and go through as many cases as humanly possible. These are all the reasons that are for dissolution: spouses, personality, professional goals, all hosts of things. They could be good, they could be bad. Perhaps your partner's spouse gets a great new job in a different area and they need to move. That's a great reason that your partnership may need to dissolve. But the more you can address up front, the easier it is. Because again, you're talking about two doctors, if you look on the right, two doctors within that single box, that single corporation that are operating everything. So just as I say that, every single one of your partnership situations will dissolve in some case. So planning for those and planning for as many cases as possible is vitally important. I mean, it's why having competent legal counsel that knows dental practice transitions and knows dental practice partnerships is vitally important if it is that you're in a partnership or you're thinking about going into a partnership. These can be, again, very, very difficult to break apart. So the more you can do up front, the better it is. So an alternative solution to the partnership is this solo group. And so you can see the structure on the right, but to talk it through, essentially each doctor owns their own corporation. Over it, there's an umbrella corporation owned by the two doctors' corporations. And ideally, those two corporations will operate almost independently under that umbrella corporation with only shared expenses, say like rent, paid in the umbrella. The benefits of doing this is that you have practice autonomy. If you each want to run a practice a very different way, and you're significantly just using this for space sharing, you're able to do that. You don't have a conflict. It's also the highest profitability of any ownership modality. Because again, you get to operate your practice, buy the things that you want to, and run it the way that you want to, with the benefit of the sharing. The complications are these are can be a little bit more complicated to put together, and you really need counsel that has done this before. And again, you need cross agreements for death and disability. So who's going to buy out what? Overall benefits, though, included in this, and I've done this before, is if Dr. 1 is ready to retire before Dr. 2, we can sell and evaluate Dr. 1's practice on its own, transition it to a new practitioner, and have just Dr. 1 replaced, where Dr. 2 continues to operate. And they do it side by side. And again, because they're owning and operating their own practice with their own staff, their own phone number, their own set of way of doing things, we have something that we can sell and we can transition when the time comes. So of all of the ways of putting multi-doctors together, this is my favorite. Practitioners like you usually typically like to be autonomous. You like to know what to do, but you also like to have a colleague close by, and this provides for that. So again, you can run your own practice, you can share some expenses, and then you have the flexibility when the time comes to transition to do what you need to do. So this is called a solo group. Again, my favorite, but a little bit more complicated to put together. So as we come back and we look at this graph, again, either one of those ways, I can get you to the far right pretty quickly, because again, you have the autonomy to do that. And especially in a solo group, if I can get two practices operating in that area of optimum practice, then we're in a very nice place where you both can very much enjoy yourself. You get the opportunity to cross cover for each other in the case that you want an extended vacation, or perhaps, a family member, you get sick or something. But you also, again, have the autonomy to run the practice that you need to. Let's talk about another way, though, to quickly grow a practice, and that would be teaming up through a merger. So we're going to do that, and this is, again, acquiring the goodwill of a practice and merging it into yours. So this could be in the case that you're a multi-doctor location, or it could be that you're a single doctor location and you're just looking to grow your practice quickly. When these opportunities come up, I think that they are the best way to grow your practice quickly. They are significantly more return heavy than would be advertising. So for dollar, this is really your best investment if you have the opportunity to do it. So let's look at a couple of scenarios. Let's say your practice before merge is $600,000 and you have overhead of $378,000. So the total net income that you take out of that practice is around $222,000. The target acquisition is $300,000 of collections, and that's carrying currently about 68% overhead. We're going to look at two scenarios that you get to take in 75% of those patients, or scenario two, you only get 50% of those patients. So in the 50% scenario, you can see that collections were 600,000, and you take in 50%, so roughly $150,000 additional collections, and you're now at 750,000. Your overhead goes up just a little bit, and your total take home from that is 292.5. We haven't factored in anything on this, and that's what I'm going to do now. So let's take a look, because we're going to look at debt service for you actually buying that. So let's say you don't pay cash, but you assume a 5.5% note, and we're going to do that over 5 years, which is actually very short for the market right now. But as far as the 5% goes, that's actually a little bit on the high side as well. So there's debt service of 30%, 60%, and 100%. Basically, your choice of paying $100,000 to get that 300, $200,000 to get that 300, or bolded at the bottom is 300,000. You're going to pay 1 times collections to bring home that debt service. I'm sorry, to bring in those collections. You see the whole table here, and I'm sure you can pause it so you can take a look if you'd like to, if you're watching this on demand. But if you look here, your total net income before merge was $222,000. In the scenario, the worst case scenario, which is the bottom right, where you only bring over 50% of the patients and you paid 100% of collections, your total net income is $223,000. So basically, you just over broke even. You were just as the same. And I highlight this because this is like a worst case scenario. In almost every one of these cases, we see that the practitioner brings in significantly more than 50% of the patient base, and even more than 75% of the patient base. So if you were to finance that and only bring over the 50, but knowing that you're probably going to bring in more, you are making money. So essentially, you can pay 1 times collections to bring in those patients. This is why it's the most profitable. It's the most active way to do this. And essentially, if somebody calls me and says, this opportunity is on the table, I say, you pay whatever it is that you need to, because you will make that money. Because the other thing that this graph doesn't show you, or this table doesn't show you, is that this is an annuity. You've now brought these patients into your practice. They are staying in your practice. So we are looking at just the first year after transaction, or the first year of transition, but that's not the case. These patients are going to stay with you going forward. So you get to continue to do that crown and bridge work year over year over year over year over year. So again, this is 1 year of modeling, and it's without further growth. But it's to say, if you have the opportunity to acquire a patient base and you're looking to jump your practice very quickly, this is a way to do it. And you can pay whatever it takes to do it. Now, you want to make sure that the practice is similar to yours and be able to merge it into yours, and obviously very close to yours. But this is a huge opportunity that is typically undervalued by you as practitioners. And as we go into the potential of tighter times, being able to acquire something, grow your practice, and pad your net income and pad your practice could be hugely beneficial to you going forward, both near and long term. Again, you'll have a larger practice going forward as well. So whether we're talking about merging practices together or any case of multiple practices, there are a lot of factors to consider, especially in the case that you're talking about bringing 2 practitioners together as partners. Do you plan to be equal partners? Are you of similar age? That's something to plan for and transition down the road. But in any case, whether you're an owner or a purchaser, I will give the same advice. I would like you to be equal partners. So if there are 3 of you, it's 33 1/3%. If there's 2 of you, 50%. The rationale is that if you are not equal partners, then you do not have an equal say. You actually have no say, whoever is the junior partner, if you will. So everybody should be equal partners to be able to operate the practice together. So again, that's primarily for a partnership, but it may be for a merger. If you're merging into a partnership for a future buyout, that is a way that we do grow practices over time. So it's something to consider as well. When you talk about any one of these cases and bringing 2 practitioners or more together, are the practices that you're bringing together of similar size and complexion? What is the makeup of those practices, both payer and procedure mix? Are there different values for the practices? And if there are different values, how are we reconciling that? If there are tangible assets that are not being used, what are we doing with those tangible assets, and who gets the value of those, or who's just disposing of them? How are we even migrating management software? Ideally, they're the same, but they may not be. There may be staff issues, and ideally, again, if you're a general practitioner or anyone with a hygiene program, You have hygienists that will be moving over in some sort of merger or partnership overall. But then how do you deal with things like health insurance or pension, time off? And how are you providing leadership to that team if there are two of you in a practice? And again, this is where the operating agreements are vitally important to determine how you hire, fire, discipline, and work with different team members on the overall team. Then what's your overall exit strategy once you're going to be there? And again, is there an outright sale or buyout of one of the partners? And again, this is where you talk about the cross collateralization and insurance on different partners. So then as we get into these months ahead and this time ahead, how do you identify whether you actually are in decline? Some of these early signs to keep an eye on are hygiene cancellations. Again, if you have a hygiene department, hygiene cancellation overall is a leading indicator. The hygiene care is a driver of your restorative treatment. So when you start seeing hygiene collections tip up, cancellations tick up, then your restorative schedule is probably going to tick up with holes as well. So really targeting in on hygiene cancellations and keeping those low is vitally important. If you see an increased delay in starting or accepting treatment, ideally we'd like to see you somewhere between 70 and 80% for acceptance. If you're exceptionally high, it could indicate that you're underdiagnosing or underpresenting treatment. This point may also materialize in just requests for additional treatment plans or just different options. Maybe you've historically only given one option and maybe somebody starts asking you for a second or a third option as well, just because they're looking at finances, they're trying to figure out what they can do. Other things that could come up would be requests for payment plans or additional use of payment solutions, i.e. like care credit. This could mirror local strains in your overall economy that you could be feeling anyway. It could be a stronger focus in a practice if you're full cash or fee for service or UCR, but this could come up in insurance for co-pays as well. You should accommodate, but please monitor because those collection costs will increase. Things like care credit, all of those third parties, even credit card collection fees are higher overall than obviously collecting cash or checks. So it's something to monitor. If you're a specialist, anything above could apply. Plus, obviously, practitioners who are referring to you may slow. They may start taking those endo or surgical cases that they would typically send to you that are maybe they deem easier, and you only see harder things. So those are all things that for you to keep an eye on. But again, these are all items for you to be discussing with patients, as we talked about early on, about the importance of dental care and the importance of you as a provider in their overall health and why it's important for them to follow through with care and the treatment plans that you're suggesting. It's not just for aesthetic reasons, it's for nutrition and every other component of health. So communicating those will also potentially help these concerns. We hear about competition a lot, and competition overall, to me, is not a practitioner next door. It's not practitioners in the area. It's actually this. Well, it might not be this. It's actually changing this to this. So I really view your competition is something like buying a new TV. It's really that discretionary expense. It could be vacation. It could be, a new technology piece. It could be an addition to a home. But your competition typically is not yourselves. You are typically not competing against other practitioners. You are competing against this discretionary acquisition. A lot of televisions now, the bigger screen televisions are somewhere between $1,000 and $1,500, similar to what a crown fee is costing. So that's where that choice gets made. And again, where that choice and what that conversation with the patient is important. So what can we do to avoid mistakes or really continue to establish your practice? First of all, if we talk about you looking forward, one of the mistakes to avoid would be signing up for discount fee plans. Okay, this may be a very short-term fix, but a very long-term effect to your practice. I've done this long enough to live through multiple versions of recession, and in those cases where practices have come out of it, they say, you know what, I started taking all of this insurance and I was never able to get back out of it because I was a fee-for-service practice before. So these are very difficult to fix later on and could affect your practice value down the road. What does this mean in real terms? This is kind of what it costs and what your earnings per hour for a full fee UCR crown. And that $1,500 range, by the way, is about right for the most of the country. So if you're significantly less than $1,500 for UCR, and I understand a PPO reimbursement fee may be less, but if you don't set your UCR high enough, then you're never going to be able to negotiate with the PPOs. But if you look at this, it takes you about an hour and 3/4 to do it. You have a lab fee, you have supply costs, you have your fixed expenses over that hour and 3/4, and your earnings per hour on this is about $216. I bring this up to show you, this is 90% and this is 80%. And this could be any discount. So I bring this up now to talk about bringing insurance into your practice and something that will never get you out of it. But a 20% discount because of a PPO plan is not unheard of. It's actually probably a pretty low discount for most PPO plans. But when you inject that into your practice and you start seeing those patients and you convert them from a UCR 100% to something that is discounted at 20%, your earning per hours went down from $216 to less than $40. You don't get to change, you won't change your lab. You're not going to change your supplies. Your fixed expenses are going to stay the same. You're not going to do it faster. So all it does is eat into your profitability. And again, so in the case of bringing in insurance in the short term, that may get you more patients now. It may help you with cash flow for the short term, but you're not necessarily making more money to do that. And then when we come out of whatever recession it goes on, if we do get there, you are stuck with those insurance plans, and then you have to go through a plan of divesting. Just for a note, that $40 an hour for a hygienist that gets paid $350 per day, that's $44 per hour. And $44 per hour right now is pretty inexpensive for most hygienists. So essentially that 20% discount that you're giving in UCR for, again, anything, it could be PPO plans or just friends and family, gets you paid per hour less than a hygienist. So fees are important. Fee increases are important. We talk about this almost every presentation. All of these fees continue to go up, even in challenging times. And especially your home costs and your retirement needs, they continue to increase. So not only do we need to look at managing how much you're decreasing, and essentially, again, in bringing in PPOs, but then also making sure that you continue to raise your fees. Other things to consider, how you're approaching your patients. Please avoid being overly aggressive or even underdiagnosing treatment because you think that they can't afford it. You don't know what a patient can afford. You need to provide the care. And again, confer to them the importance of the care. Also, don't be inflexible as far as payment arrangements, but again, something to be monitoring. If you're going to have internal payment plans, please make sure they're written down. So if something does happen to you, it's not just in your head, or if your front desk person leaves, that not all of that is lost. Written payment plans, if you have them in-house, are vital, but certainly be flexible on payment plans if things do get tight. Be careful about changing staff, whether it be termination or separation. It's very hard to replace. Many of us went through COVID, had many changes in staffing, and we went through years of trying to get staffing back into the practice, so it's very difficult. Another thing would be drastically modifying your hours or adding points of stress to your staff. They're already stressed enough. Work with them. They're part of your team. They're part of your success overall. In all the mistakes, don't panic. Look, challenging times are temporary, and dentistry has proven to be hugely, hugely resilient to dips in the economy and overall strains. So keep your head down and do quality work and work with your patients and work with your team and create contingency options, which is why we're talking about things early. So alternatives overall to anxiety for hygiene appointments, strengthen processes, make sure you're reappointing in the hygiene chair. Hygienists should be active in confirming, updating upcoming appointments, even in addition to digital reminders, having them on calls. Again, if you start going through cases where there are cancellations, have them use that time to reappoint and reaffirm that patients are coming in for their other appointments. If a patient talks to someone on the phone and confirms, they are significantly more likely to make it to that appointment as opposed to just confirming a text message or not getting a confirmation at all. So if you have hygienists that now have time on their hands, they have time to then confirm other appointments and especially to reappoint and work for future appointments. Cancellations overall are team responsibility because cancellations can be on your schedule as well. Front desk should have a quick call list, but then hygienists should be responsible for proactively working to fill appointment slots. Even dental assistants can help do this. Everybody can take a part of this to be able to continue to fill as many slots as well. And maybe you're incentivizing to fill empty spots in the schedule. So again, that goes to unappointed staff time. If there are holes in schedules, we're reviewing charts, we're looking at treatment that can be brought into the practice, reaching out to those patients, confirming appointments, everything that shows the practice cares about that patient in coming in and in the treatment that you've presented because it's important to their health. So everybody, that's a team it's a team thing to do. They can also work on reorganizing or cleaning the office space, completing other non-clinical tasks. Everybody can be paid to be doing something throughout the day, which is why you can afford to then keep those staff and work through this time because everybody's working as a team. Definitely continue marketing though. Don't tail off. Make sure your name is still out there. Make sure it's relevant, both external and internally. That's a time to really push forward with your marketing so that you can set yourself up for success in the future. Again, this goes back to the discounted insurance plans. Resist getting patients in the door over bringing in quality patients to fill your schedule because, again, they become less profitable and they become the work that you don't want to be doing. And that doesn't work for your practice. Keep your head straight on what your practice is. Do your best to continue to target and bring that patient in the door and operate that way because it will keep your staff happy, busy, and you in a better mindset overall and providing the highest level of care overall. At the end of the day, the idea is plan, plan, plan. Don't panic. You're going to work through this. Again, dentistry is very resilient. Part of the way that we talk about planning is through valuation. We can identify value, we can identify opportunities to grow and strengthen your practice. We look at financials, patient base, equipment, location, market trends. This is how you can make decisions not only about selling and transitioning, but future planning. So 5 or 10 years out, this is very, very important. It's also needed in the event of an emergency to protect both your practice and your estate and family. And again, as we talked about partnerships or multi-doctor, it helps you understand what the other practice or the practice overall is worth. So if something were to happen, you'd know what to do. We have different methodologies, including the asset summation, where we add your tangible and intangible assets together. The guideline transaction or market approach, where we look at comparables in the marketplace and what is sold to compare them to yours. And then we have the income or the capitalization of earnings, which is probably the most complicated, where we're looking at income and expenses to figure out your practice. We look at a third-party owner and post-provider earnings. And then we have a risk factor, which equates to essentially a required return on investment. This is very similar to the EBITDA. EBITDA is typically leveraged by DSOs or larger transactions, but they're also looking at what that core earnings is and then how much the practice value is based on those earnings. At the end of the day, an appraiser and our team or a team of valuation analysts will look at all of these approaches together and including the income approach, which would be capitalization and or EBITDA. And then they're going to use their experience and the information and factors present to actually make a decision based on value. We have the largest database in the country of practice sales, and it continues to grow day over day over day over day. The data that I showed you at the beginning of this presentation is already out of date because we continue to evaluate every single day. As we talk about transition, and this is something we do every single time, there's obviously what we basically talked about before and I've referenced before is a planned exit strategy. But what I've also referenced is that emergency exit strategy, which is just as important. So in that, are you aware of these big topics? Within 90 days of death, only 30% of your practices will transition. Only additional 10% will transition after 90, and 60% of practices will not sell at all if you are not there to transact the practice. This means that you have to plan for this. The worst call that we get is that a practitioner has passed away. What can we do? What can we do to help? because if we haven't planned for it, we are starting from square zero, from point zero, from nothing, and we have to collect everything, and it can be very difficult to do. So you spending the time to plan for this can be vitally important. One of the things that you can do is this what if documentation. It's called a letter of instructions. We will give this to you for free. This is something for you to go through, to document. And again, whether you're a solo practitioner in a multi-doctor space, having all of this detailed for you and your family and the other practitioner and the staff to know what to do in the case that something happens to you is important. It's so important. Again, we're going to give it to you for free. There's a URL here. There's also a QR code. You can also go to the chat on the side and type in, Greg, please get me the letter of instructions. And we will get someone in touch with you to get you this information. This is vitally important. Again, we think it's so important that we give it away to you. Another component of this is evaluation. We this year just updated our documentation. It is clean, fresh, hopefully easy to access, easy to read. We look at more pieces of your practice than we ever have. And I think at most, if not anyone else in the country does. We include local demographics. We highlight our database. We look at your overhead. We look at your practice demographics themselves, as well as the local demographics. We look at, obviously, your financials. We have something, though, that's unique that no one else can do. Through our connection with Henry Schein and Henry Schein One and Jarvis Analytics, we can get more information about your practice than literally anyone else in the country. And again, this gives us a more in-depth ability to get into your practice and really evaluate the core and give you suggestions to go forward. If you think, which we think you need evaluation, there's a QR code here. But similarly, please go into the chat and say, Greg, help me with a practice valuation, and we'll get you connected. Again, having this on file, whether you're a solo practitioner or a multi-doctor practitioner, is incredibly vital. We do, again, these nationwide, and it's very, very, very important for you, and especially now, because we can, again, from that, potentially give you the consulting or get you in touch with our consulting partners or Unitas or ESS or Direct Dental or any of our partner companies to help you make your practice stronger. And again, ideally, nothing happens and everything is good going forward. But in the case that something does happen, the stronger you are now, the stronger you will come out. So as we go back to the emergency exit plan and really what we're talking about, where you should go forward, please spend time to get that draft letter of instructions and gather your important life information then as soon as possible. Practice valuation on every practice that you own, each location, if they're separate. Have all purchasing and sale agreements, partnership agreements, solo group agreements, association agreements. We're happy to take a look at them, but definitely have legal counsel. If you don't have competent dental experience legal counsel, please get in touch with us. Again, you can leave a note in the chat or we can talk to your local transitions consultant and we'll get you in touch with dental counsel that's local that can help you with local statutes and laws. Have your leases reviewed, and in any case, to suck all feedback with your CPA and attorney. There's, again, the URL for what if for that letter of instructions. Again, we think it's that important. Having your leases reviewed, I jumped over that, but it's also vitally important. I just had another phone call this week with an attorney in California, and we talked about cases where there are due on sale clauses where landlords were able to take up to 75% of your practice sale price because you operated in their space for the case of your lease. That would be in your lease. So if you need someone to review your lease, again, put a note in the chat. We can have experts that are able to do that, that all they do is lease review and work with dental practitioners. But again, all of these are vitally important, and having that team around you, whether we're in good times or bad times, and planning for the best of times and working through the worst of times, but having your construct together is super important. I want to thank you for joining us. Again, there's QR codes on the screen. If you're joining us on a PC and you have your phone available, you are welcome to put those notes over in the chat. If you have any other questions, please drop those in the chat as well. We'll get those. We will get back to you. Hopefully you found something that's worth taking. And again, ideally, everything is great going forward. But we wanted to get ahead of it as we think you should be ahead of it. strengthen your practice the best that you can. The stronger you are now, the stronger you are through anything that we go through, the stronger you are at the end of that, and the stronger you are for the future of your career, your ownership, and eventually your transition. Best of luck to you. We look forward to working with you. Thanks.